Okay, well, it's my privilege to introduce Toma Omofoye. She is a colleague and a friend and is gracing us with a whirlwind trip to Charlottesville. Thank you so much for coming. We go back a little ways with our work in Tanzania, and we work together trying to build a team of women's imagers and breast radiologists in Tanzania. It's required some team building. Sort of one step forward, one step back. So it's been this wonderful challenge and opportunity for us. And that's how we kind of came together professionally. And it's been such a joy. And even in the challenge, it's been a joy. We've spent some time over there teaching and really bringing up some of these young radiologists. So it's been really exciting. Toma did her original training at Duke. And so please don't hold that against her.
I'm being blind.
Yeah.
You don't see a lot.
Oh my gosh.
Notice the color.
Yeah.
And then-
So, and then transition to fellowship down Bendy Anderson has been there as faculty. So she's just a rock star. She pretty much has really focused in on the educational track of her trainees, and they've really done amazing stuff. So I mentioned the global health, but that's really in the broader context of the teacher and educator that she is. And you guys already saw a couple of lectures from her today, and she's just managed to shine. So I really feel fortunate to have her as a colleague and a mentor educator. So today or this evening, this afternoon, she's going to talk a little bit about that experience that we've worked to create in Tanzania across the time zone. So we're really excited to have you here. Thank you so much. Just excited about your talk.
Thank you for having me. Well, hello, everyone. Thank you for the kind introduction, Tim. Someone says that you can't give what you don't have. And I thought of that as he was doing that introduction, because he's right. We've been trying to create this team in Tanzania around breast imaging. And because he's done such a great job of creating a team among those of us who are doing the work, I think it makes it easier to try to transmit this to a new generation of trainees. So thank you for everything that you do that creates a culture for learning. So as Tim said, I am very passionate about global health. I'm also very passionate about breast imaging because breast is best. So those are my two biases of which I come into this, which means that there is a chance that, I get into, the weeds here and just get really, really, really lost in just kind of hammering this home at y'all. And if that happens, just play the Oscars music and I'll just, see myself off the stage, okay? But I'll try not to bore you. I'll just talk a bit about how I think radiology can help address global challenges in breast cancer disparities. So I have no conflicts of interest. Those are my funding sources. Our objectives today will be to describe the challenges of breast radiology practice in LMICs, highlight the role of radiologists as key contributors in addressing global breast cancer challenges, and then identify ways radiology education can contribute to reducing these health disparities. Breast cancer in LMICs is very interesting. I'm going to start with a disclaimer, which is that I don't want it to appear as though anything that I'm saying today is meant to critique the very, very hardworking people who are doing their best in the context in which they are practicing, right? And it's also really not to criticize the volunteers, the philanthropists, the non-governmental agencies that are also trying to do their best in these contexts. It's really just meant to kind of shine a light on some of the state of things and the opportunities that remain. The other thing I want to identify here too is that a lot of what we're talking about today is talking on a global scale, right? So number one, that's super egotistical of me. It's so arrogant to show up and like, I'm going to talk about the world. because I am the world expert. It's terrible. Like, obviously I can't do that, and there's no gas in this conversation, but I encourage you to find me afterwards and like, let's have a conversation about all the parts that I missed. I think that's great. The other thing is that if you have done global health work, or if you are yourself from somewhere that would count as low to middle income, you may recognize that parts of what I'm saying are not true, right? Some of the hospitals you've worked in are not faced with some of the challenges I'm describing. So I'm not trying to say that every single hospital is really dealing with all of these issues, but just that when we look at it with a bird's eye view, these are some of the common challenges in that context. And so I don't know, have anyone heard of the IAEA Imagine database? Okay, this is going to be really fun for you. Okay, when you have a second, just Google it and just wander through it. It's really interesting. So the IAEA, the International Atomic Energy Agency, tries to track kind of the state of radiology and radiation across the world. And so as part of that, they have data country by country around the average number of radiologists in that country, the average number of mammogram machines, the average number of PET scanners, that sort of thing. And it's really, really eye-opening when you actually start to look at it from that bird's eye view, not just on a ground level. So breast cancer is the most diagnosed cancer globally. It's responsible for 1 in 6 cancer deaths in low to middle income countries. I'm going to start out by talking about the Caribbean a little bit because I want us to go from home and then far away. Most people are familiar with the Caribbean because it's just next door. But what people don't know is that the Caribbean is actually a mix of high and low to middle income countries. And as part of that, the Caribbean actually faces these extremely difficult circumstances as they try to attack breast cancer. So when you look at this breast cancer incidence and mortality data globally, you see how the Caribbean region actually sort of closely mimics the data outcomes that we see for Africa. And most people are not aware of that. Also in the Caribbean, we know that it has 4 of the 10 worst breast cancer mortalities in the world. So if you stack all of the countries in the world with 4 breast cancer outcomes, the Caribbean make the top 10. Barbados has the country with the worst breast cancer mortality in the entire world. And it's just in our backyard. And so these are some of the things that we consider as we approach global disparities. Because global is also local. What we need to address breast cancer care in Africa is often what we need for the Caribbean and what I need for parts of Texas that are underserved regions, right? So it's not really about me standing here pointing the finger across the world at those other people who haven't figured it out. Breast cancer mortality has increased by 37% since 1990, with a further projected increase of 44%. And late stage diagnosis is very, very common. In sub-Saharan Africa, we find similar things. There is a predicted 70 to 100% rise in breast cancer incidence by 2040 in most of the countries in sub-Saharan Africa. However, in general, the data is extremely limited from sub-Saharan Africa about the true picture of things. We know that in most countries, it is the first or second most common cancer. 66 to 80% of breast cancer cases are diagnosed at advanced stages when it is harder to treat, and treatment is less likely to be curative. We know that in most cases, cancer care is limited to urban areas. So it's very, very centralized, which can mean that even though they may have all the same things that we have here in terms of the technology and the infrastructure, it is not as accessible to many of the people who live in that country. And also, there is a 5-year survival of approximately 40% in sub-Saharan Africa compared to a 5-year survival in the US that's closer to 90%. Some say actually much higher than that. So there are a lot of barriers that exist in this context at the individual, provider, facility, and systems levels. For individuals, education is a big thing. People have limited knowledge of breast cancer. There was a study that was done in Tanzania where women thought a painless lump was less likely to be malignant, right? So they're waiting for that pain to emerge, which often doesn't happen until it's at much later stages. And so that is also compounded by a common healthcare avoidance. So people may feel more comfortable trying to address health issues with their religious leaders. They may have concerns around a stigma that can be associated with diagnosis of breast cancer and social implications around a diagnosis of breast cancer. And so there can be up to 1.8 years between a woman's first detecting a breast cancer symptom and actually presenting for care. There is a social issue with socioeconomic status in that there are financial constraints that contribute to delays in seeking care. Even when health insurance is available, a lot of the components of care are a la carte. And so a patient may be able to present for breast imaging and pay for a biopsy, but the interpretation of that biopsy by pathology, that's a separate charge, right? And the surgeon's visit is a separate charge. And so all of that can contribute to significant financial barriers for patients. Certainly geographic barriers like we talked about. And then there's also this concern about molecular and environmental risk factors, especially with Africa. There's a lot of emerging data now looking at genetic analyses of populations in West Africa that suggest that some of the cancer subtypes that are more common are more aggressive and may perhaps be more associated with variants of uncertain significance that we see when we run these genetic analyses. So patients are more likely to be diagnosed at younger ages with more aggressive tumors. And could there be molecular biological factors influencing that, or even environmental factors around what's happening with pollution in that context? So more to come there as well. There are a lot of barriers on the provider side. Surgical care is kind of limited. You have a lot of general surgeons comparatively compared to other specialties, but for a lot of them, they don't have as much training in breast conserving surgery. But honestly, with so much late stage disease, there's limited, use of that breast conserving surgery in that context. A study that was done by Aortic a few years ago showed that 90% of people in low-income countries lack access to radiotherapy at all. So without having radiotherapy, right, you're kind of limited to mastectomy to manage these patients. With pathology, often the types of biopsies that are done are the fine needle aspirations as opposed to cores. So you don't get the information that you need for immunohistochemistry. In some countries, the immunostaining has to be sent out of the country to be done somewhere else and then returned. And so all of this, adds to significant delays for patients. In a lot of sub-Saharan Africa, patients will get empiric chemotherapy based on kind of best guesses of, what we expect to see, what we suspect the subtype would be based on a patient this age in the US. And recent data in Uganda showed, usually when you actually analyze the data on those individual patients, the guesses have not been accurate. With oncology, there's severe shortage and a very, very heavy workload. So in the US, there's a study that showed the average breast oncologist would see about 300 or so patients a year. In sub-Saharan Africa, they were seeing on the order of 500 to 8,000. And it's all patients, all sites, right? They're not really subspecializing. And often the oncologists are med-onc and rad-onc. So you can imagine the workload that's happening. And this means that there are real knowledge gaps among the providers because it's hard to keep up with all of the knowledge for all of the sites in the body as you're practicing. There are also broken referral systems where patients have to progress through, the series of care escalations. You start from a community care center through a primary center, secondary center, and a tertiary center. And at the community center, you may have community health workers that may be trained in just emergency care, or you may find people who are trained in OB care, but not necessarily the things that you can do for cancer care. You often have limited electronic medical records and minimal national patient registries. But this is the part you're curious about, is what's happening with radiology. Well, there's specific barriers with radiology around infrastructure, right? There's a Swiss cheese model that happens with technology upgrades where you may have, GE for the mammogram machine, but the ultrasound machine is from South Korea, and these don't actually talk to the same paths because that came from, you know, another place entirely. They may even have different electricity supply needs, different temperature needs in the same, all in the same department. A lot of the equipment is not functioning. And so this is a question I had to learn to ask specifically over time, because initially you would ask, how many mammogram machines do you have? And they would say, we have 7. Great. But when you're on ground, oh, none of those function. It's sort of like at my house, I have a treadmill that's basically like, well, it's the same process. So you have to ask, you know, how many are functioning? What percentage of the time is it actually functioning, right? Asking better questions. And so we know that up to 80% of medical equipment in LMICs is donated, and a vast majority of that is non-functioning, which is actually a huge kind of focus area now for the WHO. Because some of what happens is that well-meaning philanthropists, departments, you know, will say, we're upgrading our tech. We'll donate this one that still works, you know, to another facility overseas. But sometimes what happens is that that donation is not received by the person who signed for it, right? Somebody signed for it somewhere, but the people who are working there didn't know anything about it. They have to actually build out a room for it to go to. That machine may no longer have a vendor contract associated with it to actually get it up and running. And so sometimes they don't function from the beginning, or they stop functioning soon after. There's often incomplete digitization. So a lot of facilities will still print out film, which is stored by the patient. Sometimes, and I would say frequently for ultrasound, you can correct me if you think I'm wrong, frequently for ultrasound, the images are not stored at all. So it's either printed on that ultrasound paper where it degrades after a few, you know, after a few months, or it just disappears once you have enough studies are accumulated on the machine. There are often supply chain issues with consumables. So it's very easy for me to recommend a biopsy in a patient and know that whether I'm here or not, whether I follow up on it or not, that biopsy will get done. That's not the case. A lot of the times, even with best intentions, you may just be out of biopsy needles. There was a facility where they were out of ultrasound gel for a while, and just whatever shipping plans and vendor, they were just out of ultrasound gel. So everything just had come to a standstill for a while. So consumables are really important. Also, there are a lot of operational concerns, right? You have these referral patterns that are really unpredictable, because if a patient has a lot of money, they can kind of skip over some of the referral patterns. Workflows and policies are really unpredictable. They don't necessarily have a lot of processes and procedures to make sure everybody gets the same care each time for the same chief complaint. We have not seen a lot of dependence on performance metrics. There's still a lot of use of paper charts and images stored by patients. And to be fair, the patients at least are pretty good about their paper charts. I've had more issues when the paper charts are supposed to be stored by the facility than when they're supposed to be stored by the patients. The patients actually usually will show up with their chart. And then reporting is often unstructured and may not actually connect to the medical record. And so there can be a real big gap. Our group did a study on backlogs in reporting studies around the world, and found that up to 64% of facilities actually had unreported examinations, just sort of abandoned exams. There's a facility in the Caribbean that has more than an 8-month backlog in interpreting screening mammograms. Right, so that backlog in reporting is going to happen more and more, because patients are at least becoming more aware that imaging is important, and so they'll obtain the imaging. But if the radiology doesn't have the infrastructure around it to kind of close the loop, then we're kind of going to create more and more of this issue. And quality assurance and quality control has also been a really, really big need, where we see that there's a lot of basic radiation safety measures that are lacking. And Tim was working with a group who helped in Tanzania to actually put safety zones around the MRI machine. Because, you know, the facilities that I visited where the MRI machine actually has a back door that leads to the outside. Like, you literally could just walk in. I know, right? But it's just part of education. Just people are not aware that this is part of what they need to think about until you have kind of a devastating event, unfortunately. So with radiology, often there's a lack of subspecialty trained radiologists. Most countries have zero formally trained breast radiologists. Often on average, countries will have one radiologist per million population. And then there's this widening knowledge gap as we keep making new discoveries day after day and adding on new technology. There's limited training in image guided biopsies. Most of the time that's biopsies are done by surgeons. And non-radiologists often interpret imaging. In fact, in a lot of the community facilities, you'll have an ultrasound machine and there may be a sonographer there, but they kind of report to a surgeon as opposed to reading out with a radiologist somewhere. And so that relationship that we have with our technologists where we're so close and we're in tandem and they know what we're thinking is often not built into their workflow. And as for technologists, there are different kind of qualifications methods that you can use. And so it's a combination of kind of formally trained, more provincial technologists, but often people are asked to function outside of their scope. They're asked to, operate technology that they're not trained on. And often they're not trained on the important maintenance, QA and QC that needs to happen with this technology to keep it functioning. And medical physicists and engineers are rare. So I think a lot of people are aware of this, that half to 2/3 of the world lacks adequate access to radiologic services. Most people have seen this somewhere. But what you may not be aware of is that, according to the Lancet, LMICs have 5% of the resources, but 80% of the global cancer burden. And that's continuing to rise. And so some of what I think we can do as radiologists is actually tie in to what the global community is doing to address disparities. So for example, the WHO has this global breast cancer initiative to reduce global breast cancer mortality 2.5% yearly by 2040. And that looks something like this, right? It has these 3 pillars. Pillar 1 says that we're going to, promote early detection, diagnose most cases at 60% of cases at stage 1 or stage 2. Pillar 2 is that we're going to have definitive diagnosis within 60 days. So the entire workup will happen within 60 days of that patient presenting. And then, pillar 3, we're going to treat patients to completion. So if we're really looking to achieve breast cancer control with these pillars in mind, there are a few different things you can do. You can certainly address the policy, right? You have this global policy, and then nationally, each country tries to decide how they're going to implement these policies. Certainly, we want to shore up patient care. It's important to kind of shore up research to understand the scope of the issue, and infrastructure is always important. Education is a consideration as well. And I will tell you what actually typically happens as we think about achieving breast cancer control on a national scale is this, which is where ministries of health will actually, or philanthropists or non-governmental agencies will purchase a bunch of equipment, lots of brand new CT scanners, mammogram machines, all the things. And what happens is when you're on the ground, often they'll sit in crates like this, sometimes for months. Sometimes they're sitting in crates actually at the port, like literally at the seaport, which makes me worry about how well they're actually going to function once it's installed, right? And in this case, I was asking the individuals at that site, do you know what's in the boxes? They said, oh yeah, they told us we're getting, upgrades to our MRI machine and we're going to get brand new mammo with Tomo, and everybody's really excited. That's wonderful. Did you get 5 megapixel monitors for the mammo machines? And people were not really aware of why that would be important or helpful with the mammogram machines, right? So these pieces are all kind of disconnected from each other. When you ask providers who are working in Africa, what do they consider to be the highest priority in terms of breast cancer control or cancer control in general? 75% of those surveyed said education was actually the highest priority, right? How can we maximize what we already have so that we don't stay in this loop of depending on technology that becomes non-functioning? When I think about ways that radiologists work in breast cancer control, this is really what comes in my mind. I think a lot of people are aware that yes, with diagnosis, we can help with accurate diagnosis. We can minimize kind of false positives. We can stage by doing biopsies. We can do all of these things. But beyond that, we're also helping in treatment, right? We monitor response to neoadjuvant chemotherapy. We certainly are able to confirm that there's no evidence of disease. We help determine what is the appropriate surveillance protocol for the patients who are going to need surveillance going forward. And even though in the context of low to middle income countries, screening is kind of deprioritized, the WHO advises against national screening guidelines. What radiologists do in that setting is actually think through the context to say, okay, who should screen and by what modalities should they screen, right? And in what circumstances should people be screened? And so imaging expertise is really needed at every step of management. There was a paper that I saw a while ago that said, since the advent of screening mammography, breast cancer mortality in the US dropped by 40%. Screening mammography is, it really is a public health success story. It's like, that's amazing, it is. But that's not the full picture, right? It's not screening mammography, it's not a mammogram machine that is the public health success story. It's screening mammography that's operated by trained radiologists. It's that expertise that is the public health success story. And that needs to be part of the conversation as we approach all of these things. So, the WHO also says this, that it's estimated 70 to 80% of diagnostic problems can be solved through the basic use of radiography and or ultrasound. And you all are in this room with me, and you know what I'm talking about, right? So in our practice, there are a lot of cases in which a patient comes in with breast cancer, and we don't necessarily need to have an MRI in every single one of those patients. We know which patients need it. For the other patients, we can use ultrasound, not just to look at disease in the breast, but to look at the axilla, right? Level 1, level 2, level 3, look at the IM lymph nodes, look at superclad lymph nodes. I can start to tell you some of where I think that stage is going to be, just using what is this more basic technology, because we have the expertise with which we operate it. So I think of the role of expert breast radiologists as being to provide specialist care that is resource adapted, stewarding limited resources, providing leadership in practice so that we're also helping to create protocols for the technologists and create guidelines for our referring providers around the best use of technology. We want to foster interdisciplinary work, provide community and stakeholder education, addressing gaps in research, and providing guidance on national policy and technological advancement so that it is really sequential as opposed to being kind of more of a Swiss cheese pattern. So what are some strategies for education in this setting? Well, we know that in sub-Saharan Africa, there's this critical shortage of radiologists. In this image are showing that of the 54 countries in Africa, only 18 of them, as of 2021, had radiology residency training programs, okay? But 18 of them do. And so within that context, we know that there's sort of infrastructure and resource around education already, in a context now where we can figure out where can we add fellowship training, where can we shore up resident education as well. Overall, we face a lack of programs. Curricula challenges are plentiful, often curricula are non-uniform. Because so much of, I think, medical education has been apprenticeship-based, it's really dependent on what patients happen to come in the door at the time that you're in your training program. And so if you don't have a clear outline of objectives that you want all these trainees to get outside of what they get through apprenticeship, you can see how trainees from the same program can have really different experiences and different knowledge base. You often have curricula that are static or maybe focus much more on disease processes that are common in high-income countries than what's actually common on the ground. And when you have clinically overworked faculty or no subspecialty trained faculty themselves kind of influencing that curriculum, that can be a challenge. So a lot of what people have done, and rightly so, I think, is spent their effort in serving as visiting professors, right? To try to spend some time shoring up education wherever they could. But I would say this, is that we should keep in mind the context in which we're practicing. And so part of what has happened is as there's been more reform around education in general, there's also more idea of what would constitute best practices. And that conversation is not had as much in global health. But we do know that some of the best practices that have been identified in other medical literature, medical education literature, is thinking about creating curricula around contextualized aims. So for example, we've been in Tanzania now for several years, and we've had cases of infection with processes I've never seen in my life, right? I've always just thought, mastitis, staph, whatever. We've seen Pseudomonas mastitis, seen tuberculous mastitis, cases that even when I tell, the writers of the breast imaging textbooks here, like, I just didn't even know that was a thing. And so you have to have an understanding of what's available in the context and feed that into creation of the objectives that are being made. It certainly needs to be co-constructed with the people who are on the ground, and the content that's selected that affects both how material is presented, but also how the solutions are presented to that material, right? Are we recommended MRI on every one of these patients or PET-CT? It has to be connected to what is available in their referral patterns in that work, and it has to be open to critique and feedback. And so that's been a big part of our work, is actually publishing some of what we're doing, which opens you up to, critique of the peer reviewers, reviewer number 2, that can be harsh, but it makes us better each time, right? We iterate and get better, which leads us to the final piece, which is that it has to be continuously updating. Curricula has to be continuously updated. We can be very tempted, I think, especially as visiting professors, to have our pet topic that we present on, because it's the big thing that all of our colleagues here were really fascinated by. But then when we go and present in that context, it really just may not apply at all. And so, eat humble pie enough to take that lecture out of the rotation and actually substitute it with one that's valuable. So I'll tell you a bit about what we do with the RSNA GLC. We've been developing a women's imaging fellowship program in Tanzania. And this is an RSNA-wide program to really move away from visiting professorships, right? They wanted to create consistent faculty that would take a cohort of trainees through their educational program. Most of them are 2 or 3 years, and then hopefully also create an enduring relationship at the end of that training. But these GLC programs are situated in the context in which these trainees are going to work. So it's not just about providing them exposure to what we're doing here, which is beneficial, but really trying to create education in the setting in which they will eventually practice, so that it better fits the context. And so the first site was in South Africa in 2020, where they have musculoskeletal and cardiothoracic imaging. Our site is Tanzania, which is the second, where we have women's imaging and neuroradiology, separate programs. And then Ecuador, which Juliana Bueno is a part of, does musculoskeletal and cardiothoracic imaging. And then Indonesia was just announced last year with women's and abdominal imaging program. And so what we do here is threefold. It's capacity building. We're creating this formal curriculum, developing fellowship-trained women and breast radiologists locally. But we also simultaneously have to create a breast imaging service, right? There's an existing radiology department we have to integrate a breast imaging service into. And so as part of that, we have to create protocols for the service, providing, image-based interventions, standardized reporting, so that people start to learn how to interact with our service, both the ways in which they send patients and the ways in which they receive reports from us, and how to move forward with that. But we also have to, as part of the project, leverage available infrastructure. So use the locally available technology, develop and adapt breast imaging processes so that they work with the available technology, again, potentially can be scalable to other LMICs. One thing that's really interesting about Tanzania is that because of its location in East Africa, it actually serves as a big hub medically, right? You see a lot of patients who will get transferred from Kenya to Dar es Salaam to get treated. You see patients who will come from a lot of other East African countries to Tanzania for treatment. But you also see a lot of medical trainees who come and get their training in Tanzania to go literally all over the world. And so at M&H, which is the hospital in which we work, they've had an IR program which has been very successful. But as part of its success, it's now training people all the way from West Africa. So they recently graduated the first only female interventional radiologist who's now practicing in Nigeria, right? And so then she starts to plant a program there to start to train more and more people. So that's part of the idea of this RSNA model, is that you want to be able to kind of disseminate the work into that local context. And so some of what we do in this work is, I know it's a busy slide, but I'll talk through all of it. Yes, of course, there's a shortage of breast radiologists, a shortage of experts. We want to train them. We want to provide this level of care for patients, and we're excited to do that. But also, part of what we're doing is also addressing these other challenges, like an inefficient breast health referral system. And so we're training our radiologists now to not just be radiologists, but also be patient navigators, right? We're also, part of their work now is actually performing RAP-PAC. We did a survey on a facility in Nigeria. How many of the radiologists there who perform biopsies actually do RAP-PAC concordance when the results come? And it was about 40%, right? So just that's the idea of owning a patient and their entire trajectory, the throughput throughout your department and then into the rest of their care is part of what we're trying to imbue into the system. While we do this, we're always doing this with the idea of trying to address the infrastructure, right? We're using ultrasound as a first line imaging modality, but also where possible, trying to upgrade infrastructure. So through some very strong advocacy, they just got a GE mammogram unit donated. But as part of that, then we're also training them on quality assurance processes so that we're able to get the maintenance out of this machine and get high quality out of this machine for the long term. And we've started to encourage a lot more multidisciplinary collaboration in this center. So a lot of these centers did not have multidisciplinary team meetings or tumor boards. And so the radiologist being the one who's like, let's pull the pathologist and the surgeon into a meeting and discuss some of this is an important part of, I think, the work that needs to be done as part of creating greater capacity. And then, of course, working on infrastructure and implementation of all of that. So part of what happens with breast cancer inequality is that, we know that the lifetime risk for developing breast cancer in high-income countries is higher than what it is in low to middle-income countries. But the impact is different in those countries when patients are diagnosed. The survival is much lower in low to middle-income countries when women are diagnosed. And beyond survival, we also see the social impact of cancer where, greater than 60% of people with cancer experience anxiety or depression. More than 70% have financial distress. About a third of cancer patients or their caregivers become unemployed. With breast cancer, there's 2.1 maternal orphans that are created for cancer death. And because cancer affects 2.7 million women in this age range, right? This age range where your late 20s to your early 50s, where you contribute to your household, to the GDP, to all of the things that you think are part of the prime of life. There's a huge GDP impact from women in low to middle income countries being diagnosed at younger ages and dying at higher rates than we would expect in high income countries. When I was young, I went to actually went to boarding school. I went to an all-girls boarding school. And this was the motto of our school, was if you educate a man, you educate an individual. But if you educate a woman, you educate a nation. I didn't say it, y'all. I'm not trying to offend the men in the audience. This is not for me, but this is an African proverb. And the idea behind this is the thought that women tend to be influential leaders, right? They go into their homes and they influence their children around healthy behaviors, healthy choices. If I purchase a piece of exercise equipment, the only people who use it more than me are my kids, right? Just because that's just part of what they do, is that mimicry. And so as we spend time thinking about how we build capacity, anything that we do that influences the health of women or the education of women has a ripple impact in families, which ripples into communities, which ripples into a national scale. part of what's been really interesting for us is that as we train women's imagers, right, in Tanzania and a few other places where we're doing this now, in Zambia, Nigeria, we find that the first volunteers, the pioneers of this, are often women. So they themselves are experiencing more professional, leapfrogging, right? They experience more professional development by participating in this. And in their education, they bring along the patients, they bring along the community with them by doing community outreaches and becoming this source of expertise for a woman who may not be as comfortable going to a male physician for care. So as we train breast radiologists, there's impact certainly on patient care, but also on communities and on providers themselves. So I'll summarize here to say that, I think one of the driving goals for us in working in global health, speak for everyone in global health because they elected me the leader. One of the driving goals for those of us in global health is really that where you're born should not affect your likelihood of surviving cancer, right? It's such a trivial toss of a coin. And it's important to try to provide the same care everywhere. So breast cancer, to summarize, has the significant burden and generational implications. And as breast cancer continues to rise, addressing that severe radiology workforce scarcity in sub-Saharan Africa is really critical. And as much as we can, trying to tailor subspecialty education is a key component of addressing the global breast cancer control goals. The capacity building in breast radiology has implications both for patients and professional equity outcomes. I think that there's a lot of the work that we do that we just never know the full effect of it. We never know if people remember what we talked about after we gave a lecture or after we taught or after they graduated from our program. There's so much of it that is just into the ether, right? Who knows? Who knows? But I think that one of my favorite things about global health work is that it tends to be so communal. It's very much a community, and people come together to support each other. We, call on the faculty in IR to help support the breast radiologists or breast radiology trainees when they have biopsies that they are kind of unsure of, right? We continue to support each other in trying to debrief after each trip when somebody's down there, or, when I'm in Tanzania, I'm texting Tim what's 2 a.m. for him, going, okay, I have the situation here, how do we navigate this? It's really a great place to build a community. And so, this is my pitch, that if you are interested in participating in global health work, if you want to do work virtually, if you want to do work in person, there are a lot of ways to serve and be part of this big thing. And I can't promise you that at the end of the day, there'll be a hospital named after you. But I suspect that, you're not looking for that anyway. What you may have is the opportunity to help one young professional help develop their sense of self as they grow in this field, and maybe they see the ripple effect down the line in their career. So thank you all so very much for your time and for your attention, and so many people to acknowledge, because it is a team effort and a lot of people really work very, very hard to make it possible for us to do this and for me to be here. So thank you very much. And that's my contact in case anybody.
That was great. Thank you very much. You mentioned early on in the presentation that there's this increase in incidence. What's driving that? Is it diagnosis? Is it genetic factors? Is it environmental factors? Is it just everything?
Yes.
Mm-hmm.
Yes, exactly. The truth is we don't know what's driving it. There is some thought that, all over the world, people are adopting a Western lifestyle. They're having kids later, right? Because more women are now able to go to school. They're having kids later. They're having fewer kids. They're breastfeeding less. They're eating less healthy foods, more sedentary lifestyles. Okay, maybe. But the rate at which that's rising still outpaces what you would expect, right? And at that point, then you would expect every country to be growing, to be having an incidence that's growing at essentially the same pace, but that's not what's happening. So there is some concern that there are real environmental factors that are at play here that we don't know yet. So there was some research that was presented at SBI that showed that there is growing concern around pollution and what that does on a cellular level. And I have to tell you, I heard that, and the first thing I thought is, are you telling me that those social media influencers who've been talking about inflammation in our bodies the whole time, like, are they right? Possibly right. But yeah, there's this thought that, yeah, there are these like environmental factors that are which would make sense, right? Because that is something we've seen pollution really kind of logistically increase, right? On a logarithmic scale, I mean. And so, yeah, that is something that could be part of it. But the answer is we don't know. We don't know all the details of what is happening and why it is happening that way. But that calls for research. And it again leads to why we need more experts in this area, because someone here can't take up the full mantle of that research in the way that somebody who's living and working in that context can do, right? You need people who are trained enough to say, I see this problem, and now I want to address a research question around it. But the only way we can do that is to have more experts. Yeah, but nobody knows. Yeah, please go ahead.
Thank you for your talk. That was great. You mentioned that the WHO had this like goal to reduce breast cancer mortality. Did they provide any sort of like suggestions, especially for like low-income countries, or was it just something they just put out and they just said?
Yeah, so you're right. So that was the first part. That was the first step. And so now they're going through and trying to look at the implementation of these goals on a country by country basis. So the Caribbean has been a big area of focus now for the WHO around this, right? Because the data is so striking. And so they're doing a series of things, right? They're trying to address policy, going country by country to identify. They bring in experts, a surgeon, an oncologist, a radiologist, all of that sit together, and you go through and you work with local experts to identify the actual needs in this context, and then to help with drafting national guidelines. And then there are also organizations that help with donating the infrastructure. Now, to be fair, I will say that there was some study that looked at imaging for 11 cancers. And they discovered that for those 11 cancers, if you scaled up imaging around the world, so if people now had the appropriate CT scans or mammography or whatever for those cancers, it was something like $180 to 1 in terms of return on investment. You get $180 for each dollar you spent, because it was so significant in terms of being able to actually have outcomes in improved survival. So there are also plans to improve infrastructure in these countries, but I think WHO, and we're all finding that the infrastructure by itself, the technology by itself, doesn't work if it's not accompanied by training programs. So that's a lot of what we've been doing. MD Anderson is an official collaborating center with the WHO for breast cancer. I think breast and cervical cancer. I think there are people who collaborate with them on other cancers. And so part of what we do is, once they've identified these countries, we have to create programs really sustainable. So a lot of it is virtual, so that it's ongoing, sustainable programs. People are able to maintain continuing education in that way. I will say this though, to their credit, if you think about cervical cancer, that's a success story. What has happened with cervical cancer in the last 20 years is unbelievable, right? Because there was a time where I felt like it was almost as much of a death sentence as an ovarian cancer diagnosis. And now you have entire countries where it's all but eradicated, right? So I think breast cancer is trickier. I'm not sure that we have, until we have a vaccine, right? We don't have that big bullet the way cervical cancer did. But I do think that this idea that we need to create expertise is a key component of what they're doing. And then they bring in the experts to have the experts guide them on what's the next step in kind of implementing this policy. So we'll see. Please go ahead.
Thank you for your talk and building on what John asked. So one of your points at the end is that one of the things that drives this global inequity is a scarcity of specialists,
Yeah.
in particular breast imaging specialists, and mentioned that the investment in equipment,
Yeah.
the return on investment is huge. What we've experienced in the United States is a proliferation of this equipment, which has led to the proliferation of imaging
Right.
without a concomitant rise in the number of radiologists, and it's resulted in a severe workforce shortage here. How do you combat the same thing happen in our already resource depleted regions, whether that be the Caribbean or sub-Saharan Africa?
Yeah, I think that's a beautiful question. And the answer is number one, I don't have the answer. That's the truth. I have theories, though, if you want to hear them.
Let's hear it.
So, I love that question. I think that's great. And this is where I'll admit that my optimism is probably unfounded. But in my head, I feel like if you raise up trainees, right? Because these are pioneers now, with the mindset that this is the you have a shared goal, that you don't want to end up in the situation we're dealing with today. So be really strategic about how you create your national screening guidelines, right? And be really strategic about how you create your appropriateness criteria as to what is needed. I think that that's one thing. It's like creating a set of pioneers that have a similar vision around that balance, that delicate balance between what is really necessary and what is available, right? So that they're doing that well. I think the other part of it is this. So a lot of what we're doing is focusing from the radiologist aspect, but there are a lot of people in global health who actually focus from the technologist aspect. Because like I said, a lot of the technologists, there's just a lower barrier to entry, right? They may not need 8 years of education to become a technologist. They may have 6 months or 3 months or whatever. But I think that there's opportunity there in creating sort of teams of technologists that focus with, like John Shield at Vanderbilt has done this work with this condensed bio-rad, right? It's a very simple sort of triage tool so that if a patient presents to a community health center and there's just an OB midwife there, they know enough to triage, this is a cyst, you're fine, but you don't need to essentially engage with, more advanced technology versus this is something that's complicated. You can go ahead and go for a referral. But now, when you give those community health workers the same language as the language that you've given to your, most trained, this patient can skip all of these steps that generate all this additional paperwork and imaging and all of that, and take this, sheet that says, from your condensed virus, so it's suspicious, needs biopsy, and go all the way to the end. So the thought is ultimately to try to create a system where at the different points of entry, you're trying to streamline care from the beginning. And I do think that that's probably more acceptable in a lot of African countries, probably than it would be here. I think the US really prides itself on precision medicine. I'm from Texas, right? Being individuals, being cowboys is a big thing, right? Like it's really about what's perfect for me. And so I deserve to have every test that's been created. But I think a lot of the patients who are in this context actually sort of have this love-hate relationship with, formal medicine to begin with. So they're actually more amenable to the idea that they don't want to have the latest and best of everything done to them. They're willing to kind of engage with it in these kind of discrete amounts. So that's my hope.
Thank you so much. That was
Thank
amazing.
you.
Oh, so great. And it was really inspiring to hear about, your passion and, that I share. And it's really interesting, sort of like when we think about our roles and the trainees that we sort of drag along with us. And having done this for many years, it's really amazing to see how much more we get out of this experience than you might expect.
Yes.
Which is really strange. It's like, it's not that we're not passionate, it's not that we're not professionals about it, but it's just every time you come home and this sort of out of bounds, refreshed, and it's really been really cool to see how the trainees have become repeat customers, and it sort of builds as part of their career. And so just to kind of refresh that pitch for getting involved early, especially for the trainees, it's whatever strikes you, it's probably going to be a rewarding experience. We've seen that time and time again.
Absolutely. And I will tell you how much I learned from those cases, right? Like
That's so true.
Pseudomonas mastitis. I'm sorry, what? Tuberculous mastitis. You know, I was talking with Priya about it. Just, wow, I think I had a case like this like 5 years ago or something. And I didn't even know that was a thing. But it was interesting then because now there's certain populations that I feel like I can approach with more confidence around patients who are underserved, patients who are presenting at later stages, delayed diagnosis, those patients who have been more hesitant to engage with care. It's the same toolkit, right? Global is local. It's really the same toolkit around how do I engage with them in our community here, and how do I broaden my differential diagnosis around that? Oh, it's well water. Oh, okay. I'm going to put all these things on my differential now that I didn't even know to do before. And so it's actually, yeah, it's enriched my experience as a radiologist here a lot too.
Any other questions?
No, I just, thank you, Toma.
Thank you so much.
One of the interesting things of teaching in a research-lived setting is that you have to adapt your teaching to the needs of that community. The teaching here, we teach with unlimited resources, right? So our differential diagnosis go with whatever is possible, and you have the resources to prove that or not. But in a resource-limited setting, it's a much more useful and narrow way of going to what's useful, so you know what you have, the resources that you have for that. And I think that's something really important to bring here.
Yeah.
You know, like as we
How to
start
streamline
thinking,
it.
right,
Yeah.
to avoid the situation that you're saying where we fall in the, right, like you have all these resources, it doesn't matter how much you're gonna waste in a way.
Yeah.
But when you have the limited resources, you really need to make, like, use them right and teach for what's useful for them.
Yeah.
And it's a really good exercise.
Yeah.
But
Absolutely. That's fine, please. How was your experience been in Ecuador?
well, I haven't been to Ecuador. I direct the global learning centers, so
Mhm.
so I oversee those activities that are happening in Tanzania, South Africa actually just closed. We just opened Albania, which is the next one,
Oh,
and Ecuador started last year. So, but all of them are based on what South Africa and you guys did, because you guys are the second center that has so many, and your agreement was just renewed, right?
Yeah.
Which is great, because it really brings much more time to put those resources in place and like there. So I think the RSNA does a great job at finding those grants and really putting resources, especially with people who know and are passionate about it.
Mhm. So I had no idea that she was overseeing the center. She keeps secrets from us.
From
Right,
side-
right? Like we're
Everybody.
it's like, well, this is lovely. I have friends at the top. Like, you're like, oh, this is great. But you also have friends at the top. You can come in at the top with this whole program. Wonderful. No, thank you for everything that you do to make this program possible. Yeah, that's perfect. Thank you. Thank you all for having me.